Hello again, everybody. Hi, thanks. I don't know if you had your meal in a conscious way or an unconscious way, but in any way, it was a very healthy meal. And that's what we will talk about now, because it's my pleasure to introduce to you Philippe Kolh, and he's the Chief Information Officer of the University of Liege. And he will talk about the most important thing in life. It's about health and how artificial intelligence can play a role in health in your life. Philippe is a scientist. He's also a professor of psychology and biochemistry at the University of Liege. And he's also a good writer, which makes me happy. He wrote about 210 publications, and he enjoys also presentations because he had 240 lecturers. Please, Philippe.
Thank you very much. I have to apologize for Julien Compère, who is the CEO of the University Hospital of Liege, my boss, and could not come today. So please accept this apologize. So I will deliver a few notes on artificial intelligence and health, which is obviously a very important topic. In a hospital, as you can imagine, IT is very central. And it's extremely important for patient care. And we collect data coming from everywhere, possibly in the hospital. From the operating room, from the emergency room, from the floors, from the doctor's office, from the patient room, from the patient themselves if they see him in outpatient clinic. And a key, obviously, is to get the correct information in the electronic patient record and to make sure that there is no duplicate, that everybody who needs to have an access has an access and is using it correctly. But this also generates, obviously, a huge amount of data. So in our hospital in Liege, we are quite advanced in the way we have deployed the electronic health record. I will focus on that for a few minutes. Some of you may be familiar with the HIMSS MRAM model. HIMSS is an American-based society. I have the pleasure of being the chair of the Governing Council of HIMSS Europe for this year. And HIMSS has developed the MRAM model, which means Electronic Medical Record Adoption Model, going from 0 to 7, depending upon which functionalities are deployed throughout the hospital. And we achieved level 6 last year, just a year ago. We are the second hospital in Belgium to have achieved the level 6 after the academic hospital of Brussels, and we are the first in Wallonia. What does it mean to have level 6? It means to have a fully deployed electronic patient record, and it means two interesting functionalities that I think are related to artificial intelligence. One is the clinical decision support system, the CDSS, which will help the physician and the nurse also to decide the way they treat patients. So CDSS for clinical decision support system. Let me give you a couple of examples. So it links actually the health observations made on a particular patient to the physician knowledge, and they are a major asset of artificial intelligence in medicine. So a first example is the use of a score, for example, various scores in the emergency room. You may imagine that in the ER, the physicians need usually to have a very fast and sure diagnosis, for example, for myocardial infarction, what we call here non-STEMI, which means that there is no major change in the EKG of the patients. And there is an algorithm where we can very easily, according to the comorbidities of the patient, detect whether there is a high score to estimate mortality. And the patient that have a high score, for example, should be rushed to the catheterization room to get a full diagnosis, and whether they need PCI, so angioplasty, or surgery, or whether we can wait a few hours or maybe 24 hours before we proceed to the diagnostic angiography. Another example for a pneumonia severity index, what we call the FINE score, which, well, you can see the various elements that we collect there. which will estimate mortality for adult patients with community-acquired pneumonia, which means non-iatrogenic pneumonia. But more interestingly is the use of CDSS for computerized physician order entry, which commonly means the medication order that the physician gives to a patient. So the system will actually alert the physician for 5 possible drug-drug interactions. For example, the system is in French, it's used in our hospital, which, as you know, is in Wallonia. So, for example, an association between these 2 compounds, which may be harmful or can be actually used, but the physician should accept then the potential risk. Or an allergy of the patient, there it can be absolute. For example, if you have an allergy to penicillin, the system will tell it immediately. Or a component according to the patient, for example, the fact that we are talking of a patient who has renal insufficiency or someone who is pregnant, for example. Also, the maximum drug, we all use dafalgan, paracetamol, and the maximum dose of 1 day is 4 grams. So if I want to prescribe more, the system will provide me with an alert. And finally, drug laboratory. You can imagine that particularly in an academic hospital where we train students and residents and fellows, this is extremely important to get this type of information. I mean, obviously the physician can decide what he wants to prescribe, but he is fully informed. The second part of this level 6, so the first is clinical decision support system, where we provide some intelligence to the physician, is what we call the closed loop medication administration, or CLMA. So actually, we have 2 robots. You cannot, it's very difficult to implement CLMA if you don't have some form of robotization. We have 2 that are driven by the physician order, so what the physician prescribed, and the management of the stocks, of the medication stocks. So you can see here an examples of these robots, and they will pick units. And what is interesting is the following: the robots identify each medication individually. So for a particular patient, they are connected to physician order. So one side, the physician has to prescribe, obviously. And second, they will match each identifier, so the barcode that is on each unit, each medication unit, to 1 patient, 1 drug, 1 dose, and 1 administration time. And if the nurse, when he or she delivers the compound to the patient, if it's not the correct patient, or the correct time, or the correct dose, or the correct route, the system will say, no, you cannot give it. I mean, obviously she can physically give it, but that's not the point. So you can see here the preparation. So the rings are actually prepared by units, and that obviously replace an old system where you can imagine that the number of mistakes are much more possible and probably actually happened. And at the end, as I said, there is a cross-matching between the identification of the patient who has a wristband with a barcode and identification of the drug. So we have the system has to fulfill 5 rights: the right patient, the right drug, the right time, the right dose, and the right route. Route meaning how it is administered, is it orally or subcutaneously or intramuscularly, for example. So obviously with these few examples, I hope I convinced you that health and IT are closely linked. And they are closely linked to various things. The example of the robots, here I will give you another example of robots. The connection of things, the internet of various objects, of things. And also more and more connectivity. Connected objects are mostly used for home care, usually to ensure a link with the patient. For example, the patient has COPD, so pulmonary insufficiency, or cardiac insufficiency, or terminal oncology, and we want to have some information how the patient is doing. Maybe we need to contact the patient, or we need to call the patient back to the hospital. But these devices more and more can be used preventively. For example, for diabetic patients, yesterday I think was actually the day of the the year of diabetes. So it's a good example. The connected tools allows actually the patient to take his or her insulin units anywhere. But this information is, so the amount of units that the patient has taken, okay, with the device, is automatically sent to the electronic patient record of that particular patient, and the system can detect an error. For example, the patient should take, at that particular time, 10 units of atropine, and he takes 14 or 20, and an alert can be sent to the physician, and the physician then can possibly contact the patient or ask a nurse to contact the patient. So I'm talking here of out of hospital patient, obviously. So the Internet of Things is obviously progressing extremely fast, with an inflection point which already occurred several years ago, and you can see that according to this slide, which is quite old already, there is a very rapid adoption rate of digital infrastructure, which is actually 5 times faster than electricity and telephony. So that's not the question, is whether it's there or not. You may be familiar with the Da Vinci robot, which has been used for probably 15 years already, especially in abdominal surgery, also in CABG surgery, so coronary artery bypass grafting. It's helped the surgeon, which actually is a little removed from the patient. It's also very costly. It's about short to €1 million. Takes more time, but once you train, it's extremely interesting to progress there, and it's also certainly, probably to some extent, safer. So we have various sensors, such as temporary tattoos. It's an example from the University of California in San Diego, developed by the School of Engineering, or biostem, which is here connected to permanently sticked for pregnancy follow-up for those that have at-risk pregnancy, which are probably quite frequent, even in our countries. FDA-approved coloscopy. I read actually yesterday in the New York Times that the Food and Drug Administration actually approved, this is very unique, the first pill for syntretic patient, a smart pill, that will actually record whether the patient has taken the drug or not. You can imagine what will follow from there. We can have an interesting discussion. So the smart pill will record whether the patient has taken the units or not. Smart cloth, I will give an example of that, and obviously also 3D printing, and probably the days are not that far away, we can actually use them as a real prosthesis. So we have what we call the augmented healthcare, which is my opinion is obviously part of artificial intelligence, and augmented healthcare. There are a lot of challenges for that, so it builds tools with the practitioner that are needed to improve his or her performance, from establishing a diagnosis to providing an exacting level of care. There are two obviously very important components here for a physician. The first one is the correct diagnosis, okay, because we got a lot of sometimes possibilities, sometimes unusual case or less experience for younger colleagues. And then there is the treatment that we can provide to the patient, and obviously this is where artificial intelligence can help. So various sensors that you can see here that can be used for blood pressure measurement, heart rate, respiratory, temperature, also rheostatic parameters. There are a lot of examples. So now, obviously, to take this one step further, all these let's say, smart objects collect a lot of information, and from there this information will need to be analyzed. And this is the second part, is the data analysis. I will come back to that in a moment toward the end of my presentation, because we collect a huge amount of data. We can also use that through semantic research and try to find a lot of words everywhere, which will help also the physician and the nurse to treat the patient. And so a couple of specific projects in which we participate or did participate in the hospital and university. For example, this Interact project, which is called We IT for Health. The objective is, we got the kickoff meeting last April, it's a 3-year project, is the creation of a monitoring multi-sensor and wearable device. So for example a t-shirt, but it could be also for a belt, for example, comfortable for the hospitalized patient and compatible with the IT infrastructure of the various hospitals that participate in the Euregio ride, so including in Holland, Limburg, Liege and Aachen. So as you can see, this is first for the patient that is hospitalized, but possibly for a second project we may think to develop the same for patients that are actually ambulatory. So the idea is to collect the various information and to try to improve care according to various parameters that are developed. Now, second very important project, you may know probably that in Belgium since July 2002, so this is already 15 years old, the hospitals are actually financed according to the justified bets, what we call the certain diagnostic reality group, a level of severity, and the national average length of stay. So if you have, for example, a cholecystitis and you are hospitalized, you have maybe a level 1 of severity. If the national average length of stay is 2.4 days, the hospital will get money for 2.4 days. If you stay 3 days, the hospital will lose 0.6 days. So we send this a huge amount of information from, which is collected from the medical chart, from the nursing chart, to the federal government for finances, and we got these justified bets every year in the summer. It's actually based on the activity 2 years before. You can see this information is collected from the medical chart, from feedback that we received, and we provide actually a total of 78 files. So it's a huge amount of information that's sometimes very difficult to analyze. And that's where actually we got tremendous help from a project with IBM, Watson Analytics, is to analyze this data that we receive using natural language processing to some extent. So this means that we explore the data, find patterns and relation in the data. We can predict to learn what drive behavior and outcome, for example, in the way nurses treat the patient, to assemble, monitor, and share insights in dashboards and stories, and to refine, which means to enrich and shape the data. So there is first a retrospective analysis of all these data from the feedback that we receive, but more interestingly is to have a predictive approach. What drives behavior, activities, and outcomes of the nurse, that's why it's called LNG for nurse-related group, to try to actually predict how we can allocate nursing resources within the hospital, and that's extremely important and helpful for the way we manage the hospital, especially because we have shown short staffing of nurses. This is very common in Belgium. So the take-home message that I would like to conclude from this talk is that the digital evolution is a progress accelerator because it allows to study the evolution of a disease on a large number of patients, and it will allow to better target treatments to each individual case. So to say it in other words, we got a lot of data from a large number of patients, a huge amount of data. Analytics will help us to understand these data, otherwise it's impossible. And this artificial intelligence will help us to better target treatment to each of us, to each individual patient. Thank you very much for your attention.
Philippe, just stay a little bit on stage. It was a very interesting speech, Philippe. I learned a lot. So you got 2 robots in your hospital looking for the consumption of drugs, the patients, right place. You talked also about temporary tattoos, probably the only tattoo I only want on my body. You also talked about first smart pills, very interesting. This meeting somebody called it the Internet of Pills, and not beer, but pills, of course. And of course about the evolution of data analyzing and huge data analyzing in the coming future. There was a bold statement not so long ago that thanks to artificial intelligence, cancer would be dropped out as one of the biggest diseases in the world. What do you think about it? Is that foreseeable?
Well, I don't know. I think that the challenge obviously is to target the treatment, if you talk about cancer, to the particular patient. And how do we get data, for example, on cancer treatment? It's usually on large randomized controlled trials. Now, although these trials are very well conducted, they usually include a specific type of patient. There are a lot of exclusion criteria. So in a lot of examples, for example, the amount of patients that are included are not more than 5 or 10% of all the patients that are screened, because there are a lot of criteria. This is first. And second, they are not targeted. You obviously have to follow the protocol. So if we can go one step further and individualize the treatment according to the genomics, the proteomics, the metabolomics, the side effect of the patient, the psychological components of that particular patient, we can better target a particular treatment to a patient. Now, whether we will eradicate, probably not. Cancer is part of the getting older. It's part of also our behavior in terms of smoking, in terms of not exercising enough, in terms of also the environment, in terms of food. So we can also make certainly a lot of progress there, but we can certainly better target the treatment, and some particular treatments can certainly be cured.
So you're optimistic about it?
I have to as a physician, hopefully.
Thank you very much, Philippe.